From the American Neurological Association, I'm Adeline Goss. This is ANA Investigates. Among several highlights of the recent International Stroke Conference was new evidence supporting endovascular thrombectomy for patients with so-called large core ischemic strokes. In current practice, thrombectomy is considered for patients with occlusions of the internal carotid or middle cerebral artery who are less than 24 hours since the last known well and have a small core of ischemia on non-contrast head CT or CT or MR perfusion imaging. In other words, there's radiographic evidence that only a small core of the brain has suffered permanent injury, and a larger penumbra of tissue can be saved. SELECT-2 is a multicenter randomized controlled trial that examined whether patients with large cores of ischemic tissue could also benefit from thrombectomy. On our show today, we have SELECT-2 principal investigator Dr. AM-rou sou-RAJ, who is also Professor of Neurology at Case Western Reserve University School of Medicine. He was interviewed by Dr. Michelle Johansen, vascular neurologist at Johns Hopkins University, about what the study results might mean for stroke care and stroke imaging going forward. Here's Michelle.
Thank you so much for joining us today, Dr. sou-RAJ.
Thank you so much for having me. Pleasure to be with you and your audience.
So let's go ahead and jump right in, and let's start talking about this whole idea of endovascular thrombectomy. You know, I'll never forget in 2015, standing in Nashville, Tennessee, and us all applauding when all of those trials came back as positive, letting us know that we could take patients for endovascular thrombectomy and stroke. And it's really changed the landscape of what it is that we do. So AM-rou, could you maybe start by explaining the current limitations of endovascular thrombectomy and why expanding the indications for thrombectomy would be important?
So thrombectomy delivers mechanical reperfusion to large vessel occlusion, and those are large strokes. And it showed in those trials that you mentioned in the small core trial, so to speak, patients with minimal ischemic changes and anterior circulation, large vessel occlusion, that thrombectomy is safe and efficacious. Those trials were mainly in the early window, 0 to 6 hours. Then things transitioned to up to 24 hours with DAWN and Diffuse 3. Those trials included perfect patients, so to speak, those with large vessel occlusion, minimal ischemic changes on non-contrast CT head in the early window trial, or perfusion in the extend IA trial, or perfusion images in the late window. And those are easy targets. They have large vessel occlusion, they are harboring severe neurological deficits, and they don't have signs of extensive ischemia. So it made absolute sense that opening the blood vessel will result in improving the clinical outcome and reversing the deficit. But that left several populations untapped, so to speak. One of those are the large core population, those patients with extensive ischemic changes. And there are other populations which leaves a lot of patients with large vessel occlusion without randomized evidence and without proving efficacy and safety of thrombectomy, which what led to our exploration of the large core population.
We've thrown around this word already called large core infarcts. And in your study, you define large core using either aspects of 3 to 5 or having a 50 ml or larger core seen on perfusion imaging. And those prior trials that you were mentioning, these so-called large core infarcts were excluded. So just to make sure everybody's on the same page, could you talk a little bit about why that would be? I mean, why would we want to keep people from going for thrombectomy? I mean, you know, on a surface level, without thinking about the pathophysiology behind that, you know, you would think that excluding those patients may be unfair, but there was a science behind that. Can you talk about what the risk might be for these large core patients?
Well, when there is no randomized evidence, we look into plausibility and natural history and what could happen if you apply a certain intervention. And in this case, when you have patients with extensive ischemic changes, as you mentioned, low aspects on the non-contrast CT head or large core on perfusion imaging, the risk-benefit ratio is not well established by randomized evidence. And as you are evaluating these patients in the emergency room, you start considering, well, they already have extensive ischemic changes, they already have large core, the likelihood of them benefiting from thrombectomy is lower. You also consider the risk of the intervention, opening the blood vessel on a large area of ischemia has a higher increase of hemorrhagic transformation and further complications. But at the same time, the natural history of these patients, if you don't intervene, is not good. They probably will continue to infarct. They will have very large infarct. They may have herniation and mortality. And that's why withholding a treatment on them because of those risks and because of the lack of randomized evidence that the treatment is safe and efficacious.
That's great. And so you bring up two very important points that are sometimes thought to be a little bit conflicting, and that obviously we want to do whatever we can to help our stroke patients, but there may be patients in whom we can actually inflict harm by intervening upon them. And I think for a while we thought of large core infarcts as being, dead tissue, just like you mentioned, and that by going in and intervening upon those patients that we were exposing them to more risk. And so just for everyone else to make sure they're on the same page who may have not had an opportunity to read your trial in particular, could you potentially summarize what your patient population was, what the main results were, and then we'll take it from there.
Absolutely. So you mentioned the inclusion criteria being large core, and we chose to define large core on more than one imaging modality. The non-contrast CT head, you mentioned aspects 3 to 5, in the perfusion imaging, whether it's a CT perfusion or MRI diffusion perfusion of 50 ml or more. This phase 3 randomized trial in 31 sites enrolled 352 patients. 178 patients went to thrombectomy, 174 went to medical management. Over a span of 3 years, between September 2019 and September 2022, when the Data and Safety Monitoring Board recommended terminating the trial for early efficacy. And this was the main outcome, that endovascular thrombectomy in these 352 patients provided better functional outcomes, which was the shift on the modified Rankin scale, with good safety profiles. The results, if we look into numbers, there was 60% probability of patients undergoing thrombectomy to achieve at least 1 point improvement on the modified Rankin scale, which translate to about 1.5 generalized odd ratios of achieving better outcome with thrombectomy. And additionally, the usual outcome that we look for as stroke neurologist is the functional independence, the MRS 0 to 2, and 20% in the population who receive thrombectomy achieve that, as compared to 7% in medical management. And an important outcome in this population, because these are severe strokes with large infarcts already, is being able to walk independently. Independent ambulation, or MRS of 0 to 3, in thrombectomy, in fact, doubled this outcome, 38% versus 19% in standard medical management. At the same time, you need to look at the safety. Symptomatic hemorrhage was not common in SELECT 2 and did not increase with thrombectomy. We had complications as any intervention with vascular dissection and perforation that was 6 and 4%, but did not detract from the benefit of thrombectomy and did not result in significant safety concerns.
Right. So that's a wonderful summary. So just to summarize a little bit further, you took patients that normally, according to other trials, would not meet criteria, who had an LVO either in the internal carotid artery or in the M1 for thrombectomy, and you found a shift in favor of endovascular thrombectomy compared to medical care, even among those that had a large core infarct. So there had been a study that had been released out of Japan that had showed something similarly, but we think a lot differently sometimes about the way that stroke can occur in Asian populations. So we were all very excited for your study. We already talked about how you saw a favorable shift, which means in general, people were better because of taking them to endovascular thrombectomy. But it's still a pretty significant portion of patients who are left with significant disability after taking them to endovascular thrombectomy. So if this were your dad or your mom or your sister or your brother, and they had a core of 70 mLs, would you recommend that they go for endovascular thrombectomy?
That's a great point, and without a doubt, I believe our data and what you mentioned in the Japanese trial last year, then the Angela Aspect Chinese trial this year, present unequivocal evidence that thrombectomy provide a much better chance than best medical management and the standard of care. And that's what I would tell our patients and their families. This is, as we mentioned, a severe disease with very poor natural history and very poor outcome without intervening. And providing, as I mentioned, 60% probability of improving of at least 1 point on the modified Rankin is very good, as well as 1.5 the chances of getting better outcomes. Additionally, one of the outcomes was the quality of life assessment, and thrombectomy group reported much better quality of life as compared to medical management. So this is something additional to provide, and of course you have to disclose the possibility of having a moderate level of disability. But absolutely, I would feel comfortable recommending it to a family member or any patients, because we have seen that reperfusion in this population provide a higher chance of improving the clinical outcome.
Okay, and one other thing that we frequently talk about when we talk about clinical trials, for example, is subgroup analysis. And obviously, trials are not powered to look at subgroup analyses, so you always have to take them with a grain of salt. But they're very interesting. They can be thought-provoking, idea-generating. So, and looking through your paper, and I encourage people to read it, you broke down patients based on mismatch ratio. And mismatch ratio is something that we frequently talk about when we talk about perfusion-diffusion mismatch. And the one that's thrown around a lot is greater than or equal to 1.8. But you also looked at a subgroup that had a mismatch ratio of greater than or equal to 1.2, as well as some other subgroups that were of interest. The one I want to point out, though, is thinking through that group that maybe didn't have a significant penumbra core mismatch, meaning even though they had a large core, the penumbra around that core, the tissue that we thought we could salvage, was not necessarily all that large. And you looked in that patient population, and you still seem to see, even though it's a subgroup analysis, a benefit in taking those people for thrombectomy. So then the elephant in the room, right, AM-rou, becomes, what in the world does our perfusion imaging actually mean? And is there a possibility that the way that we think about penumbra today is not the way we're going to think about penumbra tomorrow? And do you think that maybe this whole idea of what is salvageable and what is not may change over time? Or do you think there's limitations in the way we think about it currently?
Yeah, I mean, that's a great point and very good summary of some of the results and the aftermath of what could that mean. But I think it, as you mentioned, it opens the door into many possibilities. What is penumbra? Is the treatment effect is just because of that, or is there a new layer of the degree of ischemia and reversibility? All of those are important, and we will be looking at them. I think till we have a full picture of that, I don't want to call either way whether you should or should not use perfusion. And this is the reason why we did it with multiple imaging modalities. We need to do these further analyses to understand well how to interpret some of these findings.
And I understand exactly what you're saying. I think that people would love to pin you to the wall and say, you know, hey, getting CTP or even MR perfusion takes a while. It takes some time. It takes resources. It takes a staff. So if we really don't think perfusion matters all that much, do we just sort of, you know, throw it to the wind and just take everybody for thrombectomy? But, you know, I think there's probably caution in thinking about that. And I'm sure you agree.
I think I can fully understand some that would interpret the results in this manner, because mismatch didn't matter, quote unquote, in the trial. So why why doing perfusion? Why, I mean, if the patients benefit, the patient benefit. As I mentioned, I think there are further analyses that we need to look into. Which patients were those who did not have mismatch? What was their core size? Was there a difference within the same aspects with different core volumes in terms of the outcomes? You mentioned the patients and their families and how to introduce the treatment to them, and what is the likelihood of achieving functional independence, which is the likelihood of achieving ambulation, and which one of the imaging modalities, whether it's the non-contrast CT or the perfusion, would correlate better with it. I think all of those things that we need to look into, and then other analyses are coming, and we will present them at the European Stroke Conference, and probably you could bring me back and we do another podcast to talk about those.
That sounds great. I will also be at the European Stroke Conference, so I'll be excited to hear it, and we would welcome you back anytime. There's always limitations inherent in every research study. We don't have time to go through all of them in about a 20-minute podcast. If you were to be your own critic, what would you say is sort of a major limitation for people to think through as they're reading your article?
Sure. I mean, whenever you stop a study early on, you might exaggerate the treatment effect. So that's one limitation. Additionally, some of the patients had a large core on one of the modalities, not on the others. Some of the patients who were enrolled based on the aspects may have small core on the perfusion, but we pre-specified a solution for that by having a very stringent subgroup of patients with large core on CT and perfusion, and the treatment effect and the results were maintained. So those are the points that I would be criticizing myself as the PI for the trial.
And as good PIs do, it's always easy to find the holes, but I congratulate you again on this. I think it's very thought-provoking. It's a very important concept. So what do you think are the next steps? Where do we go from here?
Well, I think we started this conversation with you mentioning 2015. And I think I'll take you back a few years before, when we had unsuccessful trials, or I should say trials that did not show benefit of thrombectomy as compared to medical management. Then we moved to benefit in small core patients in the early window. Then we moved with DAWN and Diffuse 3 to benefit up to 24 hours. So we came a long way, and now we can deliver effective, powerful treatment to many, many more patients and improve their clinical outcomes and get them back to their families and to the society. But that's not the end of it. I think there is much more work to do, because we mentioned in large core that there is a significant number of patients who ended up with severe disability still. Even in small core population, there is a 50 to 60% of the patients who may not achieve modified Rankin 0 to 2. I think optimizing the care after thrombectomy, looking further into adjunctive agents and therapies along with reperfusion, whether it's immunomodulation or thrombolytic agents to improve reperfusion and get faster reperfusion, are important venue to look at. I think the window might not stop at 24 hours, and we may open it even further. And I think there are some populations that just in large core still untapped with milder strokes and more distal vessels that can be looked at, and hopefully we'll get more and more indication and more effective treatments. It's all started with TPA in 1990s, and reperfusion was the mainstay, remains the mainstay, and hopefully further opportunities are extended to more patients.
That's perfect. I completely agree with you. I think stroke is a wonderful field to be in. I think there's still a lot that we can do for our patients. I think understanding what the anatomy means in light of advanced imaging, in light of the patient sitting in front of you, and understanding risk and benefits of procedures as you counsel patients is all goes into being an excellent clinician. Congratulations again on this. Thank you so much. And we're excited to see what else it is that you do in the coming months to years.
Well, thank you so much for having me. Pleasure to be with you, and hopefully we'll come back to talk about further publications and treatments.
That was Dr. AM-rou sou-RAJ, Professor of Neurology at Case Western Reserve University School of Medicine, interviewed by Dr. Michelle Johansen, vascular neurologist at Johns Hopkins University. ANA Investigates is the official podcast of the American Neurological Association. The show's producers are members of the ANA Education Innovation Committee, chaired by Megan Ritchie. I'm Adeline Goss, podcast host and executive producer. Our program was produced today by Michelle Johansen, Joe Carrera, and me, with help from Jen Hurley. You can listen to past episodes of the show and access all of the ANA's educational programs at myana.org. That's it for ANA Investigates. See you next month.